Chair. So, for people who don't know me, I'm Marie Crofts. I'm the Chief Nursing Officer at the Integrated Care Board and the SRA for maternity services within the ICB, and I've been working closely with Helen and others on this case for change. I know that committee previously has seen the maternity health needs assessment. I wasn't at that committee, but I know that the committee has seen that. So this case for change sets out why services need to change. It doesn't propose potential solutions, because that's the next phase. And we've produced it based on a lot of evidence, a lot of data, much of which you'd have seen in the health needs assessment, a lot of information, both from that health needs assessment, but also following engagement with women across the county, with our clinicians that work in the services, so all of maternity services, including midwives and obstetricians, and people across the system that have an interest in maternity services. So just very briefly before I hand over to Helen, next slide, please, if that's okay. Thanks, Joe. So maternity services do need to change to respond to a number of things. Again, that information was in the health needs assessment. I'll just briefly run through them. One of them is around the current services and performance, and we know that we need to do things differently based on that. A huge one is around changing population needs, and again, all of that information was in the health needs assessment, and you'll have seen that in terms of what the population women in the population need now. Very much around increasing clinical complexity. Women have got multiple comorbidities now and multiple needs, so we do need to respond to that clinical complexity. We've touched on it previously, but around workforce pressures, clearly there's been workforce pressures in the system for some time, but how does that relate to what women actually need? And then changing choices and expectations, so really working with women in the community to say what do they need, what do they expect, and how can we deliver, as Chair said, very high quality, safe, effective services. Also, you'll have been aware there's a lot of national policy and guidance around maternity services, and also many independent reviews and inquiries, not least Dame Donna Ockenden's report into Shrewsbury and Telford, and subsequent reports, all saying fairly similar things. So we really need to look at that, those reviews and independent investigations, and look at national policy, of which I said there is a great deal. And to note really that the current model that we've got for maternity service is not fit for the future based on all of those changing needs I mentioned. So that's what the case for change is. It pulls all that information together. It does not at this stage propose what any potential solutions might be. That's the next phase. And through that phase, we're going to do a lot more engagement with women and other stakeholders within the community. So I'll hand over to Helen now to give the update.
Thank you. Okay, I'm on. Thank you. So thanks, Marie. And just a reminder, you have seen this, the changing needs of our population. So as Marie said, more women with long-term health conditions, there's a rise in mental health needs, increasing obesity rates. We've got reducing smoking rates, and breastfeeding initiation rates are above the national average. But both of these are sort of poorer in more deprived communities, and that does have an impact on poorer outcomes overall. So we're seeing increasing health inequalities around the county in some of our areas of deprivation in some of our communities. And I guess what we're seeing is greater demand because of some of these things for different services, including scanning services, consultant input into care, and other medical care and theatre capacity, and also mental health support. If we can have the next slide. Obviously, we spent a lot of time working with women and birthing people and our clinical teams and voluntary community sector organisations that work alongside maternity services. And we've had some key feedback to date, which has informed our needs assessment and our case for change. And what we find is, although women often describe that they do get compassionate and skilled care, some of the feedback is really inconsistent, and what we find is women do get inconsistent experiences of maternity services. There's inconsistency in communication and a need for clearer, more consistent information, a need for more reliable antenatal care, more regular postnatal checks, and better sort of communication between different teams of people looking after women, feedback around continuity of people that look after women, especially those that are more vulnerable. So people want to see more continuity in their care, and working with smaller teams of people, and really about more inclusive, culturally sensitive services. And there is something around digital healthcare records and the needs for more reliable and accessible support there, and for midwifery-led care to be more cost-effective with good outcomes. If we can have the next slide, please. So really there's three, out of all of this in the case for change, there's three sort of key areas that are our challenges. So as we've said before, there are rising levels of complexities with women. So more women require medical input, and that leads to further interventions in their pregnancies. So things like induction of labour, which can lead to more caesarean sections. So we see that more women, and this is consistent across most of Europe, more women are having caesarean sections. People's health behaviours and mental health issues that they can experience can really impact on the long-term health of the whole family, so of the child long-term as well as the woman. And obviously we're talking about the next generation, we're talking about long-term health here. That is a real challenge for us. We see persistent inequalities in outcomes for particular communities, particular ethnic minorities, or in areas of deprivation across the county. And again, people's experience of care is not consistent. So we've got inequalities in access to care, outcomes and experience. And then we've seen a huge increase in funding spent on maternity services, and our current workforce model and the utilisation of the facilities are really not designed to meet the changing needs of women. So we've got increased costs without particularly same improvement in outcomes. So in order to address these challenges, and while we can try and look for financial sustainability, we need to really look at delivering high quality, safe and equitable care, be more productive whilst providing as much value as possible, and target resources where the health needs of the population are greatest to reduce those inequalities in care. So if we can have the next slide, please, Jo, thank you. So the outcomes that we want to see, as we said, is a reduction in inequalities of outcomes between those who experience health inequalities the most and the least. Improved and consistent experience of maternity services for women. We're really interested in improving staff satisfaction and well-being at work, and we know that has an impact on the experience that women have in services. And limit the increase in spend on maternity services to the annual financial uplift as issued by central government. So we can have the next slide. So our conclusion is, as we started, we need to change the way we deliver maternity services for women in order to achieve those outcomes we want to see. There's a real need to balance the challenges of health inequalities, increasing levels of clinical complexity and resource constraints whilst operating within a financial envelope. And going forward, we are looking at having more conversations with women, building on the information that we've gathered so far to really test out what solutions people could potentially suggest to co-design a service fit for the future. Thank you.